Hi everyone, good afternoon or good morning. Good to see you all. Do you hear me? If you just say yes, hi, good to see you all. Happy Friday. So I'm going to invite Dr. Ben Gonzalez to our talk today about how to manage metabolic dysfunction and weight problems, obesity. So if you have any questions, you can drop it in the comment or the question box, and we make sure to go through some of those questions if time allows us. Okay, just a minute. I'm just accepting. Hi.
Oh, hello.
Hello, hello. Hi, Dr. Ben. How are you
I am
today?
good. It's another day in paradise.
Good to have you here with us today. Great to see you. So, I was just talking to the viewers about you and about our talk today. So, if you don't mind to introduce yourself to people who not know you here, that would be great.
Not a problem. Um, well, not to get too long, but I'll just narrow it down to this. I'm a geek. Um, I just am. I love being a geek. I'm okay with being a geek, and I'm a huge. And as a geek, I like to I love studying human physiology,
Mhm.
and it all started. For first, I was a pilot in the Air Force. I flew airplanes. I sat in the backseat of airplanes, did my job. Got cancer in the face. Had half my face taken off, thrown away, and replaced. And I was young. I was in my 20s, and but I became friends with the surgeon that did the work on my face, and I had no interest at all in medicine. Didn't think about medicine, not think twice, but all this started that ball rolling in my interest in medicine. And to make a long story short, guess that was God or fate's way of saying, "Hey, it's time for you to do medicine." And I wish it was a little easier way, but I went to medical school, University of Arizona, studied under a lot of great professors there, and one in particular, Dr. Andrew Weil. Um, who uh, who basically the father of integrative and medicine,
Mhm.
studied under him, and then I went into the military, spent 24 years active duty in the military,
Wow.
and retired about 20 years ago. I can't believe I'm saying that out loud. Um, and I did trauma and emergency medicine for those decades, for those years, and then I came out of that, went to Iraq, spent time there, and that's when I knew it was time for me to do something else. I loved every minute of it, enjoyed the work that I did there, but it was time to walk away from trauma. And I went back to my roots of integrative medicine, back to the Andrew Weil thought process um, of integrative medicine. I always loved, that's why I liked emergency medicine. I like doing everything. So
Mhm.
founded Atlantis Medical Wellness Center here in Silver Spring, Maryland, where I've been practicing over the last 18 years. And I study and teach obesity medicine, um, and in particular, metabolic medicine as it applies to women's health. Now, I am a medical feminist. I'm a hardcore medical feminist. And what do I mean? I know and I've seen it over and over and over through the decades of medicine, and from everything from emergency medicine, trauma to what I do now, about we don't take care of women very well in this country in our healthcare system.
Mhm.
Doctors are trained wrong. We're trained under the guise of a gender biased healthcare system, and we tend to take care of women as if they're men, And if you're a woman of color, it's even worse. And so that's my passion. That's what I do, and that's where I'm at right now.
Yes, you were one of my mentors at A4M. Yes, before COVID time. So
Uh,
I used to listen to your online courses on weight management. Great. Lovely. So now let's get to the juicy parts. Thanks for the introduction and amazing. So why we have such a big problem with metabolic dysfunction? We see at least 50% of North Americans have problems, complications, diabetes, weight problems, insulin resistance. Why is that? That's $1 million question.
yeah, and it's unfortunate. I mean, even within my practice, within my not my practice, rather my career as a physician, I've seen this. I've seen our population
Mhm.
go from around 18% body fat. I'm sorry, 18% body fat, 18% obesity rate to now the current, 33, 34, 35% obesity rate, soon to be 40%, and in a short period of time. And why is that? That's because one of the reasons is in the healthcare system, we focus so much on the pathology of disease and on waiting for disease to occur that we forget the number one cure of any disease, the number one cure is prevention.
Mhm.
And we forget that. So we wait for the diabetes to occur before we start taking care of it. We wait for obesity to occur before we start managing it, before we start labeling all the issues. And so the problem is we don't catch things early
Mhm.
enough. And one of the reasons, a couple of reasons, is that doctors don't have time to do that. We're not allowed in general to have, you got a 15, 20-minute appointment, if that, with your primary doctor once a year, maybe twice a year. I mean, that's not enough to get to know somebody, and then we use labs. So we put labs in front, and we say, "This is here's your labs, and everything is normal." But yet we don't, right? We say everything is normal. We'll see you next year. Or if we see something like a little bit of cholesterol level, we say, "Oh, your cholesterol's a little high, or you've got a little bit of you're pre-diabetic," which I despise that term. You're pre-diabetic. Exercise more, eat less. We'll see you in a year. So we tell those three things, and then basically the bottom line is we push the person out the door, we push them off a cliff, and they come back next year worse because problems don't get better if they get ignored. And
Yes.
that's what we do in our healthcare system, and that's why we're seeing these issues, and that's why these issues are growing despite a beautiful, wonderful individuals in our healthcare system. This isn't the doctor's issue. The doctors they care. Most
Yeah.
doctors do care, even if they don't feel like they do. You don't feel like they do. It's because they're in a system that pushes them down.
Yes. I totally agree. We keep hearing that food is medicine, but is that true? Or is it wrong? Food is not medicine, but it's an enemy. What do you
Boy,
thoughts about
boy,
food? So that's the
we could talk forever about that, huh? Just that subject alone. So interestingly, over 30 years ago, when I first, with Dr. Andrew Weil, University of Arizona, Integrative Medicine, these were the same words we used 3 decades ago, almost 4 decades ago. Food is medicine. We need to take care of the person. We need to look at the person from a holistic perspective. You can get all your vitamins from foods. Those are all things that we said 30, 40 years ago, and we're still saying the same things. That's a trick, kind of a trick statement, a misdirected statement about food as medicine. Um, because it's true. It's a true statement. Don't get me wrong. Um, Everything you put in your mouth, everything. You remember the old statement, you are what you eat?
Mhm.
That's not true. You are what you absorb. So, so we don't. If you have a bad gut and you're not absorbing the right foods or the right macronutrients through the foods that you eat, through the right foods that you eat, well then, so you're not what you eat. You are what you absorb. So first, gut health. So we got to talk about gut health. That's a whole nother discussion, right? But to address your food as medicine, everything you put in your mouth, everything you eat, either does one of two things. It either feeds the disease or it kills the disease. That's it. It either feeds the disease or it kills the disease. Now, that's how I think when I eat, and I'm a human. I love my chocolate. I will every now and then I'll get that sugar and I'll eat that sugar, and it's not, I know I'm feeding the disease,
Mm-hmm.
but you want that balance of feeding the disease and starving the disease to be like this. You want it to be like this. You want it to be heavy on the starving the disease side, right? Every now and then, okay, we're all human, but we want it to be this way. So that's one of the first things I talk to my patients about when it comes to whether food is medicine, is that I tell them, look, you have to decide what you have to make decisions based on whether you want to feed a disease or kill the disease. And if you make those decisions more on the side of killing the disease, then you're in a better place for longevity, for healthy living, and for metabolism management, and to get yourself in the right
Mm-hmm.
place. Did that kind of answer your question?
Yes, to some extent.
Yeah, we can go on forever on
I
this
know.
subject about, because we didn't talk about food type, we didn't talk about how different foods are grown, organic versus inorganic, and the term, the micronutrient and the nutrient uh, density of foods themselves and all of that. That's a whole big subject, right? So right now, if you are getting, when I grew up on a ranch. When I grew up on a ranch. We grew a lot of our own foods, and we were surrounded by farms, and so we had very nutrient rich, dense
Mm-hmm.
foods. And so, but these days now, the way things are grown, off season, and the way they're grown with pesticides, you get exposed to all these different things that the micronutrients that used to be in the foods are now lower. So you have to eat more of that thing. And then if those things are not organic, or they're grown with, or they're exposed to a lot of different pesticides, and that's a whole nother discussion about the disruption in your metabolism with these pesticides. So there's a lot to say on this subject. Um, what I How I guide my patients on choosing the different foods, and is try to choose organic in the things that you eat the most.
Mm-hmm.
Choose organic in all meats that you eat, if you do eat meat. Choose organic in those types of vegetables and fruits that are high pesticides, so strawberries, blueberries, apples, things like that. Um, and you don't have to be perfectly organic. It's sometimes difficult to do that because it's hard to find, and it can be expensive.
Mm-hmm.
But when you look at what you're supposed to eat, how much you're supposed to eat, truly, it's not that expensive to go organic if you're not if you're eating properly. Um, but anyway, that's another touch of a little touch on the subject of types of foods, and the quality of foods that we eat.
Yeah.
Another thing I like to impart on my patients about food is that you need to eat for who you are, and for your goals and the age and all that. The different um, your gut. A lot of people want to go. A lot of my patients will say, "Hey, I want to go vegetarian. I want to go vegan."
Mm-hmm.
And then they try to do that, and then they have issues. They get sick, or they're not doing very well. And why is that? Why does that happen? The reason why is because what I mentioned earlier about your gut,
Mm-hmm.
and your gut health. Your gut is trained. You have trained your gut, however age you are. So I'm 62 years old, right? I'm soon to be 63. So all it took 63 years to get my gut to where it is right
Mm-hmm.
now, right? And how I ate is what trained the microbiome in my gut to be what they are. Now, if I change my diet dramatically, my gut is trained to digest the foods that I ate before. If you're a meat eater and you want to go vegan or vegetarian, you need to ease into that, rather than all of a sudden go vegetarian or go vegan, because your gut is not prepared to digest the all the vegetables that you're all of a sudden putting in your gut. And that's the mistake people make, and dietitians and nutritionists make when it comes to advising to go vegetarian or vegan or go more plant-based. People say, I get sick. See, I'm supposed to be a meat eater. I got sick when I went vegetarian, so when I ate meat, I felt better. Well, it's like a smoker who stopped smoking, and you quit smoking. Oh, if you get the jitters, you feel really bad, and if you smoke, you feel better. Does that mean it's good for you and it's the right thing for you? No. So again, that's another thing to impart on if you're thinking about changing your diet, and food is medicine, and all those things. You need to think about easing into changes that you, or if you're a physician listening to this, or how you're advising patients.
Someone is asking, do you really think eating organic food have a big impact?
I believe it does, yes, and I especially when it comes to things like meats,
Mm-hmm.
when it comes to things like, especially in meats, and and certain vegetables. I'll give you a reason, a direct reason why. When I was a kid, like I said, I was raised on a ranch, and my grandfather had dairy farms and was worked on dairy farms. Um, and I remember in the early 70s when I, as a kid, I was in high school then in the 70s, that when the day that one of the dairies decided to use growth hormone, to inject growth hormone in the cows to get them to produce more milk.
Mm-hmm.
So we're injecting hormones, and we're told everything was safe, safe, safe. Well, we now know that those hormones get passed on to through the milk, through the meat, to the individual who's ingesting those things, and they affect your body. So organic plays a powerful role. You want to look for the things that are not for meats that are raised without hormones,
Mm-hmm.
organic vegetables and fruits that are raised without the pesticides and without the disruptions, the hormone disruptors that are found in those products. So yes, I think it does matter. Now, like I tell my patients, it's difficult to go 100%
Mm-hmm.
organic. What I care about is that you go organic in the things you eat the most, and in those high risk items like
Mm-hmm.
meats.
So, so far we touch base at food. So we see different factors. It's multifactorial, this metabolic dysfunction, food, and also we talked about stress. Did we talk about the stress? We talked about pollution, air, water, pesticides, hormone disruptors. So hormones again play an important role, especially for women, I think I see. But what are the other factors involved in this metabolic? So it's not only food, stress, I just mentioned, sleep.
Medications. So,
Mm-hmm.
so that's another thing that can disrupt um, there, different medications can cause different disruptions in your body. Simple thing, everything from simple to not so simple. There's of course, people are getting more gut issues, so they're taking more of the PPIs. They're taking more of the gut medications that deplete your body from multiple different things, everything from magnesium, B12, and so on. Um, Supplements, another thing that can actually not be good or change the way your body metabolizes certain medications and certain foods and certain toxins. Um, let's talk a moment let's talk about supplements for a
Yeah.
moment, since that's a very popular thing people do, and people look online and they want to buy this because it's good for me. Number one, just because it's good for you doesn't mean you need it.
Mm-hmm.
I have patients who will come in with bags of supplements, and every one of those things has a purpose, and they're good for you, and they might be good for you. It doesn't mean you need it, number one. Number two, just because it's good for you might not be good for you. And here's a good example. Resveratrol is a great, powerful it's a powerful antioxidant, but in the high concentrations, resveratrol can actually change the way your liver processes toxins and medications and other medications. It changed what we call the P450 system in the liver, and how and how that metabolizes and goes through the detox process in the liver. So it can change the way your medications work. Um, so, number one, just because it's good for you doesn't mean you need it. Number two, just because it's natural doesn't mean it's good for you either. Syphilis is natural. It doesn't mean it's good for you, right? So that's probably a bad example, but the bottom line is just because something's natural doesn't mean it's good for you either. And then number three, you have to be purposeful. You need to be purposeful. And there are two ways to be purposeful in supplementing. Number one, measuring. So measure the things that need to be measured. Great example is vitamin D, right? The hormone vitamin D needs to be measured in your body before you start taking it. Magnesium is a great example, too, of the way we measure magnesium isn't always the correct way. Your doctor may get a serum magnesium level, but that's not very sensitive to your magnesium levels in your body. And this is kind of important for magnesium. You need to ask your doctor for the magnesium red blood cell level. That's much more sensitive to your magnesium levels in your body. Magnesium, of course, is very powerful for both men and women, but especially for women in protecting bones. And so many other, over the 300 enzymatic processes that magnesium plays a role in. And this is how I target supplementation. I target supplementation in this way. You want to protect your blood vessels, you want to protect inflammation, and you want to protect your brain, your longevity, your brain. So that's how I think when we think about supplementation. We think about protecting blood vessels. So if you're protecting blood vessels, what are you protecting? You're protecting brain, heart, peripheral, everything. So nitrous oxide, not nitrous, nitric oxide that protects your blood vessels. Anti-inflammatories that protect your body from inflammation, and blood sugar. I'm sorry, that was the third thing, not brain, but blood sugar. Protecting your keeping that blood sugar under control. So those are the three things that I like to the three approaches or targets when I'm talking about supplements for my patients that are in front of me. And of course, being purposeful for the things that they need. For the person that's B12 deficient, the person that's magnesium deficient. You want to, of course, be purposeful with those.
Absolutely right. Now we see a lot of focus on is on weight loss, weight, but then we see some people, at least in my practice, with higher BMIs, but no visceral fat and more muscle, and vice versa. I see a thin person, low weight, low BMI, but high fatty liver. So I think we are kind of in a dilemma with this weight, BMI, and lowering the weight, but not treating the main thing, which is that visceral fat.
Yeah.
So
Yeah. Agreed. Agreed.
body composition, muscle, and fat.
The very first thing. So we're a weight loss center. My clinic's a weight loss center. We've known as a weight loss doctor, and but the very first thing, the very first thing we tell our patients in the clinic, my nutritionist does this, I do this, is that the very first thing is we say, I don't care about your weight. And I say that right off the bat, and the confusion that I see in their faces, because through the lifetime of that individual in front of me who's obese or overweight or has diabetes, has been told by their doctors, I know, I want you to lose weight, I want you to lose weight, I want you to lose weight. Told by their family, weight loss, weight loss. That's all they ever hear. And the first thing I tell them is, I don't care about your weight. It's a little confusing. And then I follow that with, what I care about the most is your metabolism. If I manage your metabolism, if we get your metabolism in the right place, then yes, the weight comes off as a side effect, as a very positive side effect. But more important than that, you can sustain that weight loss if you're managing metabolism. And so that's the key, is managing metabolism, getting the right labs, listening to the patient and listening to how they eat, cleaning up what's going on in their home and their sleep habits and all that. Doing all that is managing metabolism. And so if you do that, then that visceral fat that you were talking about, that insulin resistance that keeps a person stuck at a certain weight or at a certain body fat percentage, if that's addressed, then they start seeing, and not only watching themselves lose weight, but feeling better. How many people in your practice have you seen lose weight, but they don't feel good doing it? Going on these starvation diets or going on some cleanse or something like that. There's no such thing, by the way, as a 10-day cleanse or a 10-day weight loss program. There's no such thing. That doesn't change metabolism. It takes time. And one of the things, a good technique for the patient in front of you, or for you to think to yourself, is just telling the patient, like I said earlier, however old, let's say the person's 50 years old, it took 50 years to get to this point. Your metabolism has been built to this very point in your life. It's going to take a few weeks to get out of it, a few months to get out of it, maybe a year or so to get out of that. But once you get out of it and you get into a better place and you're on to better habits, better lifestyle, the right medications, if you need a medication or the right supplementation, the right diet, then you can stay there a lot longer, feel better a lot longer, and have a healthier lifespan.
So how do you catch that metabolic dysfunction? How do we catch it early before it gets too late? I think that's very important.
So I'll tell you how not to do it. Just getting a lipid panel, a CMP, and a CBC. That's not how to do it. So that's a small part. Even if you got all the labs, all the functional metabolic labs, that's just a small picture of who that individual is. Putting together what they say about how they got to that point, how they feel, and marrying those two, the labs and that, and putting together the systems biology approach of that individual as a whole person can give you a better idea of where their metabolism is. Now, metabolism obviously can be measured. Um, what I do in my clinic is we use body fat and we use body fat percentage and we use measurements of height and waist ratio for initial metabolic screening, and then we take the labs and metabolic to measure metabolic function in labs. You've got to check all the hormones. I don't care if you're 20 years old or if you're 100 years old. You've got to check all the hormones to get an idea of where that individual is when it comes to their metabolism, along with the other things that we usually do. And it's not just about how high or how low cholesterol is, for example. It's about what the cholesterol is doing in the body. What is your cholesterol doing in the body? Is it floating around doing its job, making your hormones, helping your brain, the cell walls of all the cells of your body? Is it doing its job, or is it doing bad things, sticking to the arterial walls? And I have a lot of patients who have their total cholesterol's in the 300s, 400s, and they're clear as a bell. Their arteries are clear as a bell. And I have other patients with cholesterol's in the 120s, total cholesterol's 120s, 130s, and their arteries are clogged with cholesterol. Why is that? Well, because you got to get a little more detail. So you got to get into the detail of some of these labs. And since I used cholesterol as an example, you got to get the particle numbers, the particle size, the ApoB, the LP little a, just to get a better idea of what the cholesterol is doing. And there's no such thing as good or bad cholesterol. Let me get that out of your audience's head. There is no such thing as good cholesterol and bad cholesterol. Every molecule, every cholesterol molecule has a role in your body. There is such thing as the ratios of cholesterols being bad or good, and the amount and the particle numbers and the size. Yes, but there's the HDL and the LDL plays a role in your body for metabolism. So anyway, that's just an example. Just getting into the detail of the labs, getting the proper labs that give you an idea early of what's going on. And I know this question is going to come up, so I might as well just say it. So what labs? Well, I could give you a whole list, and I'm not going to be able to give you the list right here and write it down so fast. But let me give you a couple of things that are important. You want to catch insulin resistance early. You want to catch that early. So, and not just with the hemoglobin A1C. So hemoglobin A1C, yes. But the lipoprotein insulin resistance marker, or better known as the LPIR marker, or free insulin will do it as well, getting the free insulin, a free fasting insulin. So those are good markers to catch insulin early. And by the way, you don't want to wait till hemoglobin A1C is 6 point whatever to call it diabetes or prediabetes. Anything above 5.4, I'm aggressive with managing. The LPIR score, anything above 40 for the LPIR score, I aggressively. I like to see that LPI score less than 25, ideally. So catching insulin resistance early. As I said earlier about the cholesterol levels, checking the nuclear magnetic resonance advanced lipoprotein levels. So the NMR, nuclear magnetic resonance advanced lipid profile. So that gives you the breakdown, and then of course all the hormones. And it's not just about how high or how low the hormones are. It's about what they're doing in your body as well. And so the free testosterone, the DHEA sulfate, those types of hormones as well give you an idea, a better idea. So that's kind of a quick.
Thyroid hormone. What about inflammation? Do you check inflammatory
Yeah, I'm glad
markers?
you said that. So I neglected that. Yes, the HSCRP, the ferritin levels, all give you an idea of inflammation. So the cardiac C-reactive protein is the high sensitive C-reactive protein. That's a good one to get. And don't be fooled if it's too high. That means there might be some other things going on. Looking at the breakdown of the white blood cells and the ratios of the white blood cells give you an idea as well. So those are some of the sensitive inflammatory markers. Now, obviously, you want to guide your labs to more specific to the individual. If they have joint pain, if they have other issues that guide you into getting some of the more specialty labs that you may need, then of course you'll need to use your clinical acumen for that. And if you're a woman, this is important. Do not ever accept from your provider this the phrase "everything is normal." If you don't feel right, if something's not right, then it's not normal. If you're not who you feel you should be, then it's not normal. What the doctor means is that to the limited ability of what they've checked and the limited amount of labs that they've checked and the limited amount of time that they've checked it, talk to you, everything might be normal, but it may not be. So you need to get into depth, into greater depth. Men are easy. Men are big babies. We're big babies. We're easy to deal with. We are. And if you're a man out there listening, I wish women were running the world because they are a lot tougher than we are. And this is through years of doing trauma. I'm telling you, women are a hell of a lot tougher heck of a lot tougher than us men.
I always say it might be normal, but not optimal. So we want it to be optimal. That's what we're missing.
And a side discussion to that is the interpretation of lab values and lab levels is another subject. Because what the lab tells the individual, the doctor, it used to say years ago when I first started medicine, it would give you a lab result and then it would say normal range. It'd say normal range. About 15 years ago, maybe a little longer, they changed that from normal range to reference range. If you look at your lab results, you'll see it says reference range now instead of normal range. So what do they mean by reference? So they mean this. The reference range is in your area of where you live. That reference range refers to the average range of the individual around your age and sex of where the average range is. So if the general population is sick, diabetic, and obese, that's who you're getting compared to.
Yeah.
And that's not what we want to be compared to. So you have to find a doctor who knows how to interpret what optimal is. Since I've used magnesium, let's just use that as an example. So optimal ranges of magnesium red blood cell levels, I consider between 5.8 and 7.0. Between 5.8 and 7.0. Another good example of that is, oh my gosh, testosterone levels and estrogen levels. Let's use estrogen. I want to bring something about men. So the reference range for men for estrogen, if you take a look at it, usually says something like 40 or less. So it means they will accept that zero estrogen in a man is okay. And that's just wrong. Estrogen protects you from heart disease, protects your brain from Alzheimer's, protects your bones. It helps men and women, of course, but we think of estrogen as women.
Yeah.
So that reference range is wrong. I like to see men, with some estrogen to help protect their brain and their heart. So there's many examples of optimals. We could go on forever about what's optimal in different labs, but those are just some examples.
And we are now seeing more and more focus on medications, to pushing down medications and treating people with the new medications in the market. So what are your thoughts on GLP-1 agonists? Do you use them? I mean, I personally think they are good when they're in right hands, not for everyone. This is a problem. This is what we see now.
So first of all, what's the doctor's job for when it comes to prescriptions? Here's our job. This is what we're supposed to do. Physicians, our job is not to write prescriptions. Our job is to try to prevent the need for prescriptions, number one. Number two, if we're if what's that? If we do write a prescription, our job is to immediately come up with a plan to get off that prescription as quickly as possible. Good examples are the PPIs for gastritis, right? Yeah. Our job is you've got 3 months to get them off that drug as quickly as possible. Now, some drugs you can't. Some type 1 diabetics, they need to be on insulin or whatever other medication that so some you can't, some is impossible, some is lifetime, but our job is to prevent the need for, number one, and then number two is to get them off any medication that they're on as quickly as possible in a safe manner. And number three is, if you write the prescription, to get them off that, to come up with a plan and tell that patient what that plan is, to get them off that medication as quickly as possible. So get to more specific to the GLP-1 agonist. So you're right. Great medications, very safe. I've been using these medications for almost 8 years now, for diabetics and for our weight loss programs. Very, very safe. We're wonderful medications, wonderful drugs, but they are drugs. They're still drugs. And the whole idea is you want to minimize the use. You want to minimize the use of, use the minimum dose, I should say, for maximum output. Right. So I as I mentioned, to answer your question, I like the medication. I like those medications, those different, the GLP-1s and GAP agonists. But unfortunately, since they became very popular about 1.5 to 2 years ago, they kind of get thrown out like candy to everyone who wants to lose weight. Let me tell you what they're not for. They're not to get into your wedding dress. So, number one, they are not for what I call cosmetic weight loss. So they're not to make your summer body lose 5, 6, 7 pounds. They're not for that. What they're for is to help manage insulin resistance and bring down the body fat percentage and get someone more efficient in the use of their blood sugar and insulin to allow for improved metabolism. That's what they're supposed to be used for. And they're supposed to be used in conjunction with other things, with a proper diet, proper protein intake, and proper micronutrient management. And so that's one of the problems I have with all these clinics that are popping up all over the place, just passing out these GLP-1 agonists, is that they're handing out these generic diets and generic exercise programs with the medication. and no real advice on their metabolism, on how their hormones are affected, on how their micronutrients are affected, and how to manage their protein. And that's how come you're seeing all these side effects. The face, the losing of the muscle, not just fat, but losing of muscle loss in the face, the muscle wasting that we see. So yes, they're good drugs. Yes, they need to be used purposeful. And frankly, if someone's on these medications for more than a year for weight loss, for obesity treatment for more than a year, they shouldn't be. Rarely do my patients are on this medication for over 6 to 8 months, every now and then up to a year, before they reach their goals and they get into a better place without the medication. Um, now, my diabetics, that's a different story. Some of them are on for life. Some of them are on, but they're on much lower doses than they used to be on because or if they came from another clinic, they're much lower doses because we've managed those other aspects of their metabolism that allows them to be on a lower drug to do better.
Yes.
Did I answer your question?
Yes, very well. And what about, so we see again, even people can purchase these medications online nowadays. So what? So they just start using without looking after their body and exercising. Any thoughts on that? Any words on exercising when you are especially on these medications that you're building muscles fast?
Yeah, these medications are not supposed to be used by themselves for weight loss at all. They are adjuncts. They are helpers for lifestyle changes. I just had a patient today. She's on her third month of the GLP-1 agonist. She was doing a good job losing weight, and her insulin resistance has improved, but I did notice she wasn't losing as much weight as I had predicted or thought she would. And then I asked her the question. I said, "So, what are you doing different as far as your diet's concerned?" She's eating less because the medication's helping her do that. But I said, "Have you changed what is it you're drinking?" Because she used to be a soda drinker. She's still drinking soda, so she's drinking soda pop. It's diet, ooh, which is worse, by the way. So she's drinking soda. She's still eating when she's still snacking, but not as much, she said, but she's still snacking, and she snacks on not grapefruit, not tomatoes, not bananas, not oranges, but she's snacking on her candy bars. But they're diet candy bars, Dr. Gonzalez. Yeah. And when you take a look at them, they're highly processed, still got sugar in it. Um, and so if the individual's not changing what got them there in the first place and just eating less of it, and they're losing weight because their insulin resistance is a little better because of the drug, what happens when they go off the drug? They're going to get into that exact same place, and we don't want that.
Even more.
So I had this yeah, even more so, right. Well, yes, even more so. And that's really true for those who are exercising, hyper exercising. They're exercising a lot and they're eating less. Their metabolism eventually slows down,
Yes.
depending on how much muscle they build. But they eventually just slow down because they're not managing the tools in their metabolism. So and we see this. We see this every January 1st, from January to March, the exact same pattern of exercising more, eating less, losing a little bit of weight, and then by March, going back to the old habits and gaining the weight back. And then the fear of the summer happening in May, and then the extremes happen again. So in May, April, May, exercising more, eating less, and maybe taking a drug. And now I'm going to take phenterine, or I'm going to take some sort of other anti-eating pill, and their metabolism slows down. They lose some weight for this little bit of summer, and then what happens in the winter? Boom, right back up, right?
Absolutely. So, I mean, again, what I think we should have, especially with people who have this yo-yo weight loss, weight gain problem, sometimes emotional eating, and a lot of times have mental health issues. So I think instead of providing these medication, some CBT therapy and having that support background is so much important, which unfortunately here in Canada we don't have access. People have to pay, and it's not
Yeah.
that cheap.
I highly, we get it. It's just multifactorial, the
Yeah.
way to manage obesity. I've got a cool trick for you. It's a very cool trick for anybody listening to this. So CBT, all those different, counseling, all these different things that can help. It takes a little time, right? It takes time and effort. Here's my quick, 60-second, um, uh, um, discussion with my patient about what to do to help with mental health and the mental aspect of this. 60 seconds. This is all it takes. I just teach them how to breathe.
Mhm.
People don't know how to breathe. If you watch people breathe, you'll see how they breathe shallow. So I have a 60-second discussion with my patients, teaching them. I give them homework. I say, here's your homework. I want you to look up the terms box breathing. I want you to look up Dr. Andrew Weil's breathing techniques. He has a whole bunch of them. You can go on YouTube and you can look up his breathing techniques. Um, just learn a simple single breathing technique that allows you to open up your lungs and do it every single day, once a day. I only ask my patients initially to do it once a day. Eventually, as they go through my programs, I ease into, okay, now let's do it twice a day. Do it once in the morning, once in the evening. Now let's do it right before you exercise. And I'm telling you, just that one thing is powerful. So I teach martial arts. I used to teach violin lessons. I used to teach diving. I was a diver in college, a springboard diver and a platform diver. Would you believe I'm one of those crazy guys that I'll jump off anything. I'll jump, no matter how high, as long as the water's deep, I'll jump off of it. So, so with all those things, the single one thing that I start with every student is teaching them how to breathe. Whether you're performing on stage with the violin, whether you're martial arts getting beat up or beating somebody else up, whether you're getting ready to do a dive off of a cliff or a dive off of a springboard, learning how to control and do deep breathing to allow that cleansing feeling throughout your entire body that relaxes everything eventually. If you make that a habit, learning how to do that, the beauty of what it does to your physiology manifests itself quickly, especially when it turns into a habit. Once a patient does that for 3 weeks, if they can do that I make them promise to do it for 3 weeks every single day. I know that they're going to do it for the rest of their life because then they feel the difference. So that's a
Yeah.
simple thing.
Just activating that vagal nerve, vagal tone. So the relaxation, that's true.
Just to
I have to start.
get your chest open to allow that blood flow through and that cleansing feeling through your entire body is what we're looking for. It's
Mhm.
not just about the pills. It's not just about exercise. I see it in the gym all the time. Actually, when we go to the gym, I see these people. They're doing a good job. They're trying to do their cardio and they're doing but they're holding their breath, or they breathe shallow, or they're not allowing that freedom for the flow of their body, the flow of their blood flow in the air, do the job it's supposed to do while you're exercising.
We've touched on so many things. You go through everything amazing, and just we don't want to keep you long. But what is any last advice you want to give to all of us?
Oh man. Uh, okay. If you're old enough to know this joke, don't eat that yellow snow. Okay, that's a joke. It's a Frank Zappa song, so that's just for you guys who are old and know that music. Um, so yeah, yeah. Less worry about weight and more worry about metabolism will go a long way
Mhm.
in curing obesity,
Mhm.
not controlling, but curing obesity. Catching things early and understanding the number one cure for any disease is prevention. Make that
Mhm.
make that an understanding, and I think um, whether you're a patient listening to this or whether you're a doctor listening to this, those basic things will go a long way in changing the attitude of what weight loss really is,
Mhm.
and what it's about and what it's for, and that we worry more about our health span rather than the moment, is powerful. I do want to say one thing about feeling good. This happened today as well. A patient said, "Dr. Gonzalez, I take this vitamin because it makes me feel better." And I was looking at the supplement that they were taking. It had a bunch of bad stuff and a lot of caffeine, some ephedra, had some other things in it. And I said, you got to be careful when you're supplementing. And this is a good kind of more specific thing for you. Um, you and I, by the way, could make $1 million in the next 3, 4, 5 months easily. $1 million. And I'm not kidding. We could make $1 million. And this is how we do it. You can take a Red Bull, those drinks. We can take the label off, rewrap the label, and call it Dr. Square's testosterone building drink. And we could change a few things in there. We could change a few to make it proprietary. And then the person could drink it and they feel better. And then they say, oh, my testosterone must be better. I feel really good. This must be good for me. Just because, right? Right? So be careful about when some people come to you and they say, I feel really good on this. I don't want to stop this. Make sure you look hard at the ingredients of what things
Mhm.
have. So that's another little quick
Just
hint.
one last question. Someone asked
Sure.
about intermittent fasting. What are your thoughts on intermittent fasting? And do you advise patients to have that? And if you do, have you seen benefits of it? And what type?
Frankly, I wish people would fast between meals.
Mhm.
I just wish that would start happening first. So fasting between meals. So you don't need to snack every day. You don't need these small meals throughout the day. That doesn't need to happen. So
Mhm.
number one, fast between meals. But yes, for intermittent fasting, I think it's very powerful. Very great studies showing that it can be powerful. The problem is um, people tend to, if you have a food addictive behavior and you're
Mhm.
going to start an intermittent fasting program, um, it can be tough to do that because your brain is wired to want that food. And if you're not metabolically flexible to handle those fasting states, then it's difficult to maintain. And we like to blame patients. Oh, you need better willpower. I mean, it's like telling somebody who has diarrhea to stop having diarrhea. I mean, it's
Yeah.
like telling somebody who has a rash or an itch to stop scratching, right? It's
Mhm.
just that part of the brain is the same part that for food addictive behavior is
Mhm.
the same exact part of the brain, the arcuate nucleus, this very small piece of the brain there that exact same place where opioid addictive behavior is, right? Where
Yeah.
salt, fat, sugar is. So it's all that same place. It's hard to so intermittent fasting needs to be done purposefully, slowly introduced. And there are some helpers out there. I love. Can I talk about a compound, like a specific compounds on your podcast here?
Yes, yes,
Yeah,
absolutely.
there's a very specific compound called the brand name's Kayla Curb, but there's a specific, and anybody who has food addictive behavior, I start them on this compound, Kayla Curb. It's an extract out of specific hops in New Zealand. Um, Anybody who's started intermittent fasting and they have this food addictive behavior issue, or they have hunger issues, or they have late night eating craving issues because of whether it's because of food addictive behavior or whether it's just a habit, that I start them on this compound. Have them do it twice a day, and it helps ease that craving. By the way, it acts like a GLP-1 agonist. It's
Mhm.
pretty powerful.
Mhm.
Just now came out in the United States. I don't know if it's available in
I
Canada yet, but
haven't, I wasn't
yeah,
aware.
I'm not sure
How
if it's
spell
available yet.
it? What's the spelling? How do you?
Oh, Kalo Curb, Calo, Kalo,
Or
Curb. Yep, Kalo
Mhm.
Curb.
What about low
Um,
dose naltrexone? Have you tried it?
Yeah,
Have you
that's
seen?
another great tool.
Mhm.
So I personally have food addictive behavior. I have that. It's ingrained in my family. I have cousins who have passed away younger than me from their obesity issues. My mom, morbidly obese most of her adult life. And so I used to use I still use naltrexone alone myself personally, a low dose naltrexone to
Mm-hmm.
help with that, and it works very well for me. I
Mm-hmm.
used to put an implant. I used a 1 gram implant in myself. That was a little much, I know, but yeah, it works very very well. Low dose naltrexone. You have to experiment with each
Yes.
patient. Some 3 milligrams works fine. Some has to be 3 milligrams twice a day. 4.5 milligrams once or twice a day.
Mm-hmm.
You'll have to play with it with the patient, and it doesn't work for everybody.
No.
But it really it can be a powerful tool. Yes, so I'm very okay with low dose naltrexone. And yes, it's a drug. And yes, we want to go as low as possible for the best for the highest effective rate to be effective. And we want to make sure that the patient's using it in a purposeful way. So what do I mean by that? Sometimes just doing a little bit of low dose naltrexone through the winter can help an individual. They don't have to do it through the summer. Sometimes, like when you go on a cruise, you can use low dose naltrexone, and that's when I use medications like phentermine. So I never use phentermine for weight loss,
Mm-hmm.
but I do prescribe it for Dr. Gonzalez. I'm going on a cruise, a 2 week cruise, a 10-day cruise. Then
Mm-hmm.
that's a useful use of a drug that can be relatively safe in looking at an individual, and that's where you can use those types of medications. So low dose naltrexone, things like phentermine, the Calocurb. I keep looking down because I thought I had my bottle right here. I do. I have mine right here. So that's the Marisate compound. So I take it.
Good.
Um, yeah, and so it really does help, especially on those stressful days when the food addictive behavior kind of kicks in.
Mm-hmm.
Um, yeah, yeah. Any other questions? I don't mind. I've got a little bit of time.
It's just amazing talking to you. I learned so much. I'm sure other people who are here, viewers, all learn so much. It's great. It is amazing. And I
Well,
wish
thank you
you
for
a very
inviting me. Appreciate it.
happy birthday in advance. We're
Thank
sharing
you.
a month.
Thank, thank you. Yeah, yeah. Whew. I can't believe it. I can't believe we're saying those numbers, 60 something. Oh my gosh. Like that. When was
Those
that
are
supposed to
just
happen?
numbers. Those are just numbers. It was amazing talking to you, and hopefully I see you in person one day soon.
Thank you very much, and take care. And everybody, good luck with everything, and stay
Thank
healthy.
you. Thanks. Great.
Bye bye.
Bye.